starting with the alveolar gas exchange. The alveolar are tube-like organs, tube-like organs are going to deliver respiratory air into and out of the lungs. And the alveoli are the sites of the vital process of gas exchange between the air and the blood. So alveoli are microscopic air sacs at the end of alveolar ducts. They have pores that permit air to pass from one alveoli to another. That provides alternative air pathways. In addition to that, there are alveolar macrophages that help to clean the alveoli. The respiratory membrane itself is a wall of an alveolus consisting of a layer of simple squamous epithelium. Those are the type 1 cells. Part of the wall of the alveolus is made up of cells. Those are type 2 cells, and those type 2 cells secrete pulmonary surfactant. Gas exchange between the alveolar air and the blood occurs through the respiratory membrane, and that would consist of the alveolar wall, the blood capillary wall, and the basement membranes of the epithelial layers. That respiratory membrane then is the wall of an alveolar cell, the basement membrane, and the wall of the membrane of the red blood cell. Walls of a capillary lies in close proximity to the wall of an alveolus. I said red blood cell before, it's capillary. Red blood cells quickly take up the oxygen that diffuses across that thin layer of the respiratory membrane. Cell membranes are permeable to the gases, carbon dioxide and oxygen. Molecules diffuse from regions of a higher concentration to low concentration. To determine the direction of the diffusion of a substance, the concentration gradient is important. Things move down their concentration gradient. And in the process of respiration, gases diffuse from areas of high partial pressure to areas of low partial pressure. That respiratory membrane is thin and gas exchange across it is very rapid, but there are factors that affect the diffusion across the respiratory membrane. Increased diffusion occurs with more surface area and shorter distance, greater gas solubility, and a steep partial pressure gradient. Decreased diffusion would occur from a decreased surface area, which can be the result of harm to the respiratory membrane. The force driving diffusion of oxygen and carbon dioxide across the membrane is the difference in partial pressures of the gases between the alveolus and the capillary. In the air, oxygen has a partial pressure of approximately 104, and in the capillary, 40. Carbon dioxide has a partial pressure of 45 in the capillary and 40 inside the alveolus. Carbon dioxide solubility comes into play with carbon dioxide as well. So at high altitudes, air is still 21% oxygen, but the PO percent oxygen decreases because the atmospheric pressure is lower. So oxygen diffuses more slowly into the blood and hemoglobin saturation declines. People can experience altitude sickness at varying degrees, but the body will attempt to obtain more oxygen by increasing heart and breathing rate and an increased production of red blood cells and hemoglobin. One particularly devastating disorder is called high altitude pulmonary edema, or HAPE. It is a severe form of altitude sickness. You can get sudden severe headache, nausea, vomiting, rapid heart and breathing, cyanosis. Hypoxia can constrict pulmonary blood vessels, sending blood under high pressure through the pulmonary circuit, raising capillary pressure, and that filters fluid from the blood vessels into the alveoli, leading to edema. So the important disorders that impact gas exchange would include pneumonia, which is an infection of the lung in which the alveoli swell due to edema. Alveoli become abnormally permeable, brings fluid and white blood cells into the alveoli. That decreases the available surface area for gas exchange. Tuberculosis is a bacterial lung infection in which the dense connective tissue tubercles or forms around the infection site to wall it off and stop it from spreading. In the process, lung tissue is destroyed, respiratory membrane thickens as those tubercles form. That reduces surface area for gas exchange. Atelectasis is lung collapse, when blood vessels collapse along with the lung. In the case of an obstruction, the alveoli beyond the obstruction collapse. Usually the functional regions carry on enough gas exchange for cells. Acute respiratory distress syndrome is a form of atelectasis in which the alveoli collapse, blood vessels and airways narrow, and oxygen delivery is severely impaired. So once we get the oxygen in the blood, we've got to transport it, and the carbon dioxide we picked up in the tissues is there as well. So blood transports oxygen and carbon dioxide between the lungs and the body cells. As the gases enter the blood, they dissolve in the plasma and chemically combine with other substances. For oxygen transport, there are two major methods. Most of the oxygen, 98 to 99% of it, diffusing into the red blood cells, is bound to the molecule hemoglobin. There is 1 to 2% of that oxygen that is dissolved in the blood plasma. Oxygen chemically combines with iron in the heme unit with 4 polypeptide chains forming oxyhemoglobin. So one hemoglobin can bind 4 oxygens. But it's a weak bond and it can be easily broken. We'll talk more about it. It's reversible for sure. We'll talk more about that. So factors that increase the release of oxygen from hemoglobin include a decreased partial pressure of oxygen, increased partial pressure of carbon dioxide, increased acidity, and increased temperature. So O2 moves from blood into tissues. However, about 75% of the O2 remains bound to hemoglobin in the venous blood system. So it's generally completely saturated in systemic arteries due to a high concentration of oxygen, but some of it is released in body tissues because of a low concentration of the partial pressure of oxygen. So partial pressure differences cause oxygen to diffuse from an alveolus into the blood. Oxygen is then transported through the blood bound to hemoglobin. The differences in partial pressure of oxygen to diffuse from the blood into the cells, fluid and cells around it, drive that force. Hemoglobin is still about 75% saturated in venous blood. P, carbon dioxide increases, so does the amount of oxygen released from hemoglobin. As blood pH decreases, so acidity occurs, the amount of oxygen released from oxyhemoglobin also increases. Blood temperature also is affected by, or it will affect the dissociation of oxygen from hemoglobin. Carbon dioxide, on the other side of the coin, which is generated by metabolic waste by the process of electron transport following cellular respiration, will diffuse into the capillaries because tissues have a higher partial pressure of carbon dioxide than capillaries. It gets to the lung in one of 3 possible ways. Some of it, carbon dioxide, is dissolved in the plasma. Some of it does bind to hemoglobin. It doesn't bind at the iron, it binds at a different location, but when carbon dioxide is bound to hemoglobin, it's called carbaminohemoglobin. Most of it is transported as part of a bicarbonate ion. So carbon dioxide will combine with water to give us carbonic acid. Carbonic acid dissociates to give us hydrogen ions and bicarbonate ion. This is why we have the bicarbonate pH regulating system. So bicarbonate ions dissolved in the plasma, and hemoglobin. Mostly bicarbonate ions, some dissolved in the plasma, and a little bit bound to hemoglobin. Something called the chloride shift occurs. A negatively charged bicarbonate ion will diffuse out of red blood cells. Chloride ions from the plasma would then diffuse into the cells, and that helps to maintain the electrical balance of red blood cells. Upon reaching the lungs, bicarbonate ions diffuse back into the red blood cells. The reaction runs in reverse. Carbon dioxide diffuses from the blood into the alveoli, and that's exhaled from the lungs. So in the lungs, bicarbonate or hydrogen ions and bicarbonate ions come together to give you carbonic acid. The carbonic acid gets into a red blood cell where an enzyme breaks it into carbon dioxide and water. Carbon dioxide diffuses out of the cell. So, oxygen, plasma, and hemoglobin. Carbon dioxide, 7% in the plasma, 23% with hemoglobin, but 70% is in the form of carbonic acid. Over the course of our lifetime, there are changes in the respiratory system. As we get older, ciliated epithelial cells become fewer. Cilia become less active, mucus tends to thicken, swallowing, gagging, and coughing reflexes tend to slow. Macrophages in the lungs lose their efficiency, leading to an increased susceptibility to respiratory infections. Breathing may require more effort as costal cartilage stiffens and postural changes change the shape of the thoracic cavity. Connective tissue can replace muscle and bronchioles that can hinder dilation. Bronchial walls can also thin and don't open as much. The alveolar wall thins and the alveoli merge, decreasing gas exchange area. But again, it's still, at least as far as I'm concerned, beats the alternative. All right, these are now posted up on Brightspace.